Hello, everyone. My name is Andrew Rentschler, and I'm the Senior Director of External Affairs at the Johns Hopkins Berman Institute of Bioethics. I'm here today with two members of the Berman community, Dr. Marielle Gross and Dr. Zach Berger. Dr. Gross and Dr. Berger are here to do a brief Q&A on some of the ethical dilemmas that clinicians are facing in the midst of the COVID-19 pandemic. Zach, I'll start with you. As clinicians are just starting to see their first patients who are diagnosed with COVID-19 here in Maryland, what are some of the biggest ethical challenges that they're seeing?
I think, and this goes to many COVID-19 related questions, that these are pre-existing issues that are more fraught, more intense, but are ever true, are even just as true as they were before. And that is that every clinician has to both treat every patient uniquely according to their own individual needs and keep in mind the needs of public health. And conversely, clinicians can't distance themselves from public health needs. They need to take an active role in the public sphere, advocating for necessary changes to preserve the public health while keeping individual patients in mind. So squaring the circle in both ways is really difficult at the best of times, and it's an even more challenging times, but it remains our professional and public responsibility.
I'll build on that a little bit, Zach. What's a situation in which what's right for public health might be at odds with what's right for an individual patient? And do physicians, clinicians face those, and how do they deal with those?
Yeah, so one of my clinical roles is as staff physician at the Esperanza Center Health Clinic, which is a community center on Broadway in Baltimore that takes care of undocumented people, most often Spanish speaking among the other languages. And there are many patients who must work right now to feed their families because otherwise they have no money at all. And we know that people are told to stay home from work, and that assumes a situation, a level of privilege where the person talked to by the public health establishment can choose whether to stay home, and their employers listen to them. And so many of my patients, especially those at Esperanza, have none of those options. I'm worried about two things, broadly speaking. One is I'm going to be on inpatient service in the hospital where I am on occasionally, but not all that often, and I'll be doing that in a few weeks, and I want to do as good a job as possible. So I'm worried about that. I'm also worried about all the vulnerable patients that we mentioned. We rolled out a hotline this week. When I say we, I'm playing a small role, but Esperanza Center together with Central Seoul and together with the city of Baltimore, rolling out a hotline for the use of immigrants to call with symptoms that might, they are worried, be related to COVID. And I'm worried about so many people with undiagnosed cases. And I'm also worried that the state of Maryland, unlike other states, is not collecting race or ethnicity data, making it impossible to figure out who are the most affected by this epidemic in the state.
So that leads me to another question, which is, so what are some of the vulnerable populations doing in the face of, and how are they affected by COVID-19? Obviously by the virus itself, but also through social changes and social impacts.
Sure. So I think the most vulnerable populations are, again, the ones that are most vulnerable to our society even before this pandemic. Those are those that are most likely to be overlooked by society in general, and those whose deaths and cases of COVID are most likely to be not counted or undercounted. So I'm referring to the elderly, the poor, the undocumented, the incarcerated, those who are stigmatized or marginalized by virtue of their health conditions, for example, those that are in chronic pain, or those that use substances, those that use opiates, for example. So all these populations are disadvantaged in the best of times, which might never have existed, but even in the worst times that we have now, they're particularly vulnerable.
Okay. So Zach, which clinicians are most vulnerable to COVID-19?
Sure, that's a very important question. And there are clinicians that fall into different categories of vulnerability. Obviously they can overlap, but the first category are people that just by virtue of being human beings with bodies have health conditions that make them vulnerable. So that could be people that are immunocompromised, people that are pregnant, people that have other conditions, that other health conditions that make them more vulnerable to the effects of the COVID-19 virus. Then there are clinicians that, by virtue of their activities as clinicians, and let me say that we should also expand the notion and talk not just about clinicians, but healthcare workers in general. So any healthcare worker that is exposed to the secretions or the droplets of patients or has more direct patient contact are more likely to be infected. And I'm thinking, of course, about those people that are most often with patients, and those would be janitors and nurses, and people that are most often exposed to bodily secretions of patients or direct care with patients themselves. So that would be anesthesiologists or nurse anesthetists, that would be surgeons, other people that have direct contact with patients, respiratory therapists. And then finally, there are people that are vulnerable by virtue of who they are and are exposed to biases or racism as present in society and exacerbated by in time of pandemic and crisis. So obviously, people exposed to racism by virtue of being Asian, for example, or by virtue of being part of a group that somebody might blame for transmitting the virus to them. So those are multiple types of vulnerability that people are exposed to. And then I think it's also important to recognize the vulnerability of trainees who are asked to assume more labor, often unpaid or underpaid labor, in a setting of debt and straitened circumstances.
That's great, thank you. So what are your, just to expand on that a little bit, what are your thoughts on this will lead in actually to the final question, but some academic medical centers who are encouraging medical students to venture into patient care, to sort of be drafted into frontline patient care? What are your thoughts on what are the ethical implications of that?
I think it depends what the relationship is. And I've seen few medical centers recognize that medical students are not just an untapped resource, they're also a vulnerable population set within a power structure. So if you're going to have medical students, for example, graduate early or encourage them to volunteer, obviously those are different cases. But if, for example, if you're going to have medical students graduate early, well, then you need to pay them properly and you need to make sure they have the requisite benefits. You should make sure they can organize and bargain for their rights. So all these things are really important.
What should healthcare systems be doing right now to protect those vulnerable groups?
Well, I can say that I think different vulnerable groups have different needs, but I think broadly speaking, I would say that budgets are moral priorities. So investing in the health of communities can and should overlap with investing in the health of trainees. And that means bargaining at a table with workers and trainees, and that means paying people fairly, and that means prioritizing the vulnerable and not necessarily the well-heeled. And these principles are difficult to implement in the best of times because of various political economic facts of our society, so they require restructuring, and it could be that in time of crisis, the impetus will be felt.
Just to add to that, I think what Zach is referring to is in the larger context of healthcare workforce shortages as a result of the direct increased risk that healthcare workers face in the COVID-19 pandemic setting. So just as a population, they are disproportionately likely to get it because we're the ones taking care of patients or screening them, et cetera. Within that rubric, thinking about academic medical centers is really interesting because we're, as academic medical centers, at the vanguard of taking care of the first patients, the sickest patients related to this crisis. At the same time, our very practice model in which teaching and education is intertwined with patient care has sort of a built-in redundancy that, the model of the medical student going to see the patient and then the resident and the medical student and then the attending and the resident and the medical student going back to see the patient just doesn't work with the social distancing and other infectious control principles that we have right now, especially when we think about disease containment and then conservation of the personal protective equipment. So while we're the ones who you want taking care of this issue because academic centers are full of the experts, at the same time they're the ones training the next generation of experts and how do we respond, we have to take care of patients in a way that we're not used to taking care of them. And then depending on how long this goes on for, the real implications for the long-term healthcare workforce and what it means to be, a medical student who is basically kicked out of your clinical rotations, because that was one of the first things that we started doing, was saying again, it's the what is non-essential, what is essential. And that is an ethically fraught, discussion, because at the end of the day, training new doctors is essential, but is it essential that you go into this one room with that one patient who has upper respiratory symptoms? Well, no. And so there's like a wide range of things between that, and figuring out where we fall now, next week, and on sort of a continually updating basis as this threat evolves is, a huge challenge. The one thing I did want to mention about the kind of related to the medical student role is about the visitors to the hospitals and the elimination of visitors, and how much clinicians are really feeling this now, because they're the ones responsible oftentimes for telling visitors they can't be there or kicking them out. And at the same time, patients, visitors, and loved ones were part of the team taking care of that patient, watching their vital signs, making sure that they were advocating for them, and forming a lot of probably therapeutic roles that we weren't necessarily giving them credit for. And feeling their absence, I think clinicians across the board sort of realizing that, they might have yet another role on their shoulders of providing emotional and psychological support that at the bedside when they actually are there.
Marielle, what ethical challenges have been raised that are specific to women's health?
Yeah, I think, when I think about this, I kind of group it from gynecology and obstetrics. And so for the first thing, from a gynecological perspective, the biggest ethical challenge, I think, has to do with the need to either delay or cancel many surgeries that are considered non-essential or elective, and deciding what surgeries are non-essential, what surgeries are elective, which ones, can we do, which ones should we modify the time frame, et cetera. That process, which is not just limited to affecting women, I think especially affects women because of the nature of reproductive surgeries, which are a substantial amount of the surgeries that we're performing in this country. Whenever you say, what's a non-essential or what's an elective surgery, the immediate thing I think people think of or might think of in this context is abortion. And so something that's already ethically fraught, just like Zach was saying, when you're already on this, on the margins or on the edge of something, and then you add the crisis to it, it puts pressure on that. So this is, an opportunity for many of the forces that are combating the availability of pregnancy termination services to make it unavailable as a result of the crisis, specifically by determining that it is non-essential or elective, and therefore a, inappropriate use of societal resources. I'd like to point out that this is not limited to abortion issues, and that there's a lot of other procedures, both minor and major, that significantly impact women's lives, that they might be either deprived of with significant consequences. And that includes other family planning procedures for birth control, but also gynecologic procedures to manage, for example, very heavy vaginal bleeding, which could become an even bigger issue if there aren't pads and tampons available on the shelves. So it's just everything kind of snowballs. The other category of obstetrics has a lot of really interesting, I think, ethical challenges. The first thing that I think of is about hospital admission for labor and delivery. This is the most common reason to be admitted to the hospital in our country. And this is at the same time when we are doing everything we can to keep people out of the hospital because of the risk of COVID-19 that we think is increased in the hospital sort of exponentially. And so you have people coming in to deliver babies being forced into this situation, or considering their alternatives. So thinking about home birth or what their other options might be has been a huge ethical issue for us that we're facing, specifically related to breastfeeding as well, in terms of our just total lack of knowledge about how this disease is really operating and how it will affect, mother, baby, and how we should, whether we should separate them or not. And, I could say a lot more about that. I think that the other sort of big ethical thing to think about in this area is about prenatal and postpartum care, which is almost a light point because we're seeing the sort of rapid implementation of telemedicine. And this is an area where, we really should have done this before. And I think even though there are people that will have additional struggles, especially people that are at the absolute poorest of accessing telemedicine, I think overall telemedicine is going to make it so much better for so many people to get appropriate health care that, that they couldn't access. So many people, for example, don't come to postpartum visits because they have a baby at home and maybe a million other things going on. But now they can get the postpartum care that they need, with the telemedicine. So that's just an example of how this might actually be helping, especially given the frequency with which we see patients in the prenatal setting is like more often than any other patients are seen under any other circumstances. So the implementation of telemedicine, I think, is really important there.
So what should academic medical centers do to protect vulnerable, not just clinicians, but also medical students, residents, janitors, as are mentioned, healthcare workers?
The things that I think of immediately are access to the personal protective equipment or the PPE, which has been woefully inadequate in our country. And, in a situation where we don't really know what the threat is or what the appropriate level of precautions are, the way, if in a perfect world, the way that we would do things is start with maximal protection and then maybe peel back layers as we learn more that this is droplet and not airborne, for example. But the reality is that many, if not most, of the providers on the front lines of taking care of patients at large right now are not, do not have the highest level of protection, the N95 masks or above, or if masks at all, because of supply shortages. And so I think attending to that issue is really huge.
Any other pressing issues that are keeping you up at night? What are you worried about right now? And what are you thinking about in terms of trying to keep clinicians safe and healthy and sane as they face this pandemic?
The sheer sort of projections that 70% or more of our population will actually end up having this virus at some point, that some epidemiologists have made, sort of brings this point home because it's just so pervasive. And our healthcare systems, I think the thing that keeps me up at night is the idea that we really don't have a learning health system, and we have not been, as a society and really internationally, leveraging the technologies that we have to identify these things, learn from them, and rapidly address them in a sort of coherent, consistent manner. Thinking about how fragmented our healthcare system is and how that contributes to the propagation of this threat is sort of one of the things that really, I think, merits the most consideration, because if we don't learn from this, it will happen again. And there are alternative paths. We could do better. And I think that the last kind of thing I'll say is that it strikes me that the long-term ethical, legal, and social implications of our response to COVID-19, both within healthcare itself and in society at large, will far outlive this pandemic. And the sort of decisions that are made now, the things that become the normative response or the standard response on all of, ethically, legally, and socially, will be our new norms in many ways, because things, I expect, will just not go back to normal.
Okay, well, with that, I want to thank both of you for your time. Appreciate spending some time answering some questions.
Thanks for having us.
Thank you. Thanks for letting us talk.
Sure.